So there's been a variety of algorithms that have been put out. This is one that I guess in the green color seems very exuberant with the big arrows, but essentially the key things to know are on the left side. Admission, day 3, day 7. And I'll refer you to, there's a nice review article in Clinical Gastroenterology last year that kind of goes through some of this also in detail. But the key thing is at day 0, the patient is coming in, they're getting IV steroids. You're essentially assuming that they're getting surgery or starting on some type of biologic agent. So the 3 days are really going to allow you to get your PPD, your chest X-ray, your hepatitis serologies, et cetera. Okay? Gives you a chance to do a flex-sig and make sure you don't have an emergent, which I talked about before, toxic megacolon, C. diff, any of those other things that are causing the problem. So at day 3 to 5, what I would say here, I guess the one that Rima put here, intolerance or failure, start either infliximab or cyclosporin. But essentially what you're starting here is one of the 2 drugs. I mean, we can talk about the utility of adalimumab, golimumab. Remember, azathioprine can take up to 17 months to work. So I think really we're talking about one of those 2 medications. And so if you don't really practice in a center that's familiar or you're used to using cyclosporin, the fact is that you're deciding at that point whether a patient needs to be on an anti-TNF or not. If a patient rapidly responds to the IV corticosteroids, meaning that it's unlikely that they're in complete remission on high-dose steroids, then you can debate whether this is a patient that you might consider putting on an immunomodulator. But for the most part, by day 3, you're starting one of these 2 therapies. And then what you're doing is that you're allowing the patient essentially to respond. And we can talk about later what's the right dose or what everyone on the panel does. But somewhere around 7 to 10 days, you'll get a clear idea whether the patient is getting better or not. And really, you can kind of follow day to day, but as many of you, out of personal experience, it's kind of like follow the bouncing ball. Some days you're like, oh great, they had 1 bowel movement. Sometimes they have 0 bowel movement. You're like, well, that's not normal. They have toxic megacolon. It's like you're almost like concerned. And then the next day they have 10. And so I think that you kind of setting these time posts is really the big thing to really get the delta. In general, at day 7, are they doing dramatically better than they did at day 3 as opposed to any spot test? And then that's where at that point you're deciding whether the patient needs to have surgery or not. So I think that's the algorithm that we practice, and I think that it's probably a useful one because although I'm sure we've all had patients in the hospital, 2 weeks, 3 weeks, you'd probably have to count that most of those patients ended up going to surgery anyway. It was probably the exception, that you were actually able to salvage and not give, not ultimately have surgery.